Hello. Um, I'm going to present this lecture about cerebral palsy. I'm Dr. Nebal Wail, a pediatric neurologist working in Children Welfare Teaching Hospital. The objectives of this lecture we are going to define cerebral palsy. We are going to review the causes of cerebral palsy, summarize the classification, illustrate the clinical presentations, outline the appropriate management and supportive services, summarize the preventive measures, and finally, we are going to outline the prognostic characteristics of cerebral palsy. What is the definition of cerebral palsy? It's a non-progressive disorder of motion and or posture secondary to an insult in the developing brain. You can see these red text or red colored text they were colored in order to focus on these three conditions to define cerebral palsy. It is a non-progressive, so you may not see progression of the illness, which may indicate neurodegenerative disorder, because cerebral palsy is not a type of neurodegenerative. It's a static encephalopathy. It causes insult or it affects the motion and or the posture. This is the second condition. And the third condition is that it is due to insult of a developing brain. The developing brain, the period of developing brain is in the first 3 years of life and particularly in the first year of life. Some resources mention that brain development continues up to 5 years of age. So it's a static encephalopathy, yet we may find some progression in the peripheral features of patients with cerebral palsy. This is due to, or this reflects, the changes in the maturation function, particularly the maturation of synapses, and the changes in the distribution of various neurotransmitters. There are many etiological factors. The most common etiologies for cerebral palsy is the prenatal and congenital type of etiologies. There is a misbelief or a faulty belief that birth insult accounts for larger percentages or larger, percentages of cases of cerebral palsy. No, it was found that less than 10% of children with cerebral palsy had evidences of intrapartum asphyxia or intrapartum lesion. The most common causes or etiological factors are the prenatal type. There are 4 classification systems for cerebral palsy: etiologic, topographic, functional, and physiological. The physiological classification is that type of a classification which describes the physiological changes in patients with cerebral palsy. So there is spastic changes which accounts for 70 to 80%. معظم الأطفال اللي نشخصهم cerebral palsy عندهم الspastic type. ممكن أن يكونوا مع mixed type other ممكن أن يكون mixed type مع other features. ممكن نشوف مع dyskinetic features, especially the dyskinetic and the spastic, which causes the mixed type. Dyskinetic type is either the chorioathetoid or the dystonic forms. This accounts for 10 to 15%. The ataxic type accounts for less than 5%, the hypotonic or the atonic type. The topographical classification, it describes, this type of classification describes the topographical pattern of involvement. Which limbs are involved? So we have a quadriplegic type, causes 10 to 15% of the cases. It involves the 4 limbs of the child. Diplegic, it involves both lower limbs or 4 limbs, but the lower limbs are affected more than the upper limbs. Hemiplegic, when one side of the body is affected. Monoplegic, one limb is affected. Double hemiplegic when there is an involvement of the forelimbs, but the upper limbs are insulted more than the lower limbs. Functional classification shows the severity, the degree of severity of the functional changes, so that it describes three types of cerebral palsy based on this classification: the mild, moderate, and the severe. The etiologic type could be the etiology could be congenital or acquired. Now, the most common type that is encountered or seen in the clinical practice is the spastic diplegic cerebral palsy. As we mentioned before, there is involvement of the lower limbs only, or the upper and lower limbs, but the lower limbs are affected more or insulted more than the upper limbs. The first indication is commando crawl. تجي الأم تقول ابني الزحف مالته يكون على بطنه commando like. And there is difficulty in the application of diaper. ما تقدر الأم تفتح رجله حتى تلبس الحفاضة because of the spasticity. The child is unable to sit. And the examination shows pyramidal features, increased reflexes, ankylosing, bilateral Babinski sign. The feet is usually in equinavarus form or posture. Usually they have normal intellectual development and minimal percentage of seizure. The main causes of this type of cerebral palsy is the prematurity. The spastic hemiplegic, when there is one side of the body, when the one side of the body is affected, usually there is delayed milestone. The mother come and said at 6, maybe it has congenital or acquired postnatal causes, but it may be overlooked, and later the mother comes and say, I feel that my child is not moving one side of the body, especially the arm, or is not catching the objects with, or is catching the objects with one arm. He's not using the other one. Or my child has delayed development, so he is unable to sit. He's 10 months and unable to sit. Or he is 18 months and he is unable to walk. This is the presenting features. Here there is an increased incidence of seizure, usually focal seizure. And again, the child shows pyramidal features on the affected side. The causes is arterial ischemic infarct at the first trimester or third or perinatal period. The spastic quadriplegic is the most severe type of cerebral palsy. The forelimbs are affected, so we expect that the insult in the brain is extensive, and there are associated disabilities and associated features like pseudobulbar signs, optic atrophy. There is an increased risk of incidence of seizure. There is, all of them have intellectual impairment. And then the dyskinetic type of cerebral palsy. Here, there is dyskinesia in form of dystonia or chorioathetoid features. It is due to involvement of the basal ganglia mainly, or insult of the basal ganglia. There is an abnormal movement and posture, and it is due to damage of the extrapyramidal system. They can be caused by perinatal asphyxia in 58% of cases, or by hyperbilirubinemic encephalopathy. Both can cause damage or insult to the basal ganglia or extrapyramidal system. Initially, the child may not show the dyskinetic movement. The child initially may be hypotonic, and then chorioathetosis appear in the second and third year of life. This is one cause or one example of how cerebral palsy sometimes can show progression of the peripheral signs or symptoms. There is a speech impairment, impaired skill hand movement, and delayed development of the motor function. There is impaired swallowing and saliva. Again, seizure can occur in 25 to 40% of the cases. And the MRI show high signal intensity at the anterior thalamus, posterior thalamus, or posterior putamen. These are the extrapyramidal system. Ataxic type of cerebral palsy is due to insult of the cerebellum. It could be due to trauma or perinatal asphyxia. There is developmental anomaly of cerebellum, and it shows signs of cerebellar dysfunction. The hypotonic type is mainly due to muscle problem. There is hypotonia, which persists beyond 2 to 3 years of age. This is very important to differentiate it from the initial phase of dyskinetic cerebral palsy. The deep tendon reflexes is normal or hyperactive. There is hypotonia, but there is hyperactive deep tendon reflexes. So there is central problem. Most likely there is central problem. 50% have cerebellar signs. The cause is unknown, and the MRI showed no significant anatomical changes. The MRI yield or changes are mainly seen in the spastic diaplegic type, where we can see periventricular leukomalacia, and you can Google image that type of insult in children with a spastic diaplegic cerebral palsy. And another changes can be seen in children with a spastic hemiplegic or spastic quadriplegic, and we can even see changes in dyskinetic. But in hypotonic, it is unlikely to see changes. The mixed type, there are mixed features. So we can find extensor plantar with extrapyramidal disease, hyperreflexia, spasticity, and contracture in a child with a front dystonia. So there are mixed features. What are the clinical presentation? The mother will not come and say, my child has cerebral palsy, and will not come and say, my child has insult in the motion or problem in his motion and posture. No, there are different presentations. The child can present with ataxia, spasticity, hemiplegia, irritability, tremors, abnormal sensation and perception, impaired sight, hearing or speech, seizure. So the mother can bring the child for seizure, for seizures, and then during the history and the examination, we find out that the child has cerebral palsy. So these are the clinical presentations. How can we diagnose children with cerebral palsy? First of all, there is no definitive lab studies. History, examination, and other studies to rule out the causes. Clinically, the child present with a different presentation, but mainly developmental delay, problem in motion and posture. On examination, we can find some changes in the like pyramidal signs, extrapyramidal signs, cerebellar signs, etc. The history might reveal the cause or a risk factor somewhere during his life or in the intrauterine life. Then investigation can be done like brain ultrasound, brain CT, MRI, and EEG in cases where seizure is present. Well, these are the investigations. How we are going to treat those children? First of all, those children need multidisciplinary team. Need multidisciplinary team. We have to treat, we have to do exercises. The child should perform exercises. We have to consider giving medications and drugs. The child may need motorized wheelchair, psychologist, psychiatrist, walkers, standing frames, ophthalmologist, communication skills, and you can Google image all these uh, to have some good images and to uh, to see some good photos about these types of or these treatment lines. For the drugs, what are the drugs used for children with cerebral palsy? We can use drugs to reduce spasticity, like baclofen, benzodiazepines, like Valium or clonazepam, dantrolene sodium. We can treat the recurrent chest infection. Those children has bulbar impairment. They are liable or they are at risk for aspiration pneumonia. They may have constipation, so we can prescribe medications for these two problems. For dystonia, we can prescribe levodopa, carbamazepine, trihexyphenidyl. Anticholinergic drugs can be used. Botulinum toxin can be injected into the salivary gland or the muscles. Some of them have excessive amount of salivation, drooling of salivation, and this excessive amount of salivation can cause other complications. So we can inject botulism toxin into the salivary gland. Surgery can be performed, especially at age of 4 to 8 years, like muscle tendon lengthening, fixed bone deformities, rhizotomies. Those children, in addition to the motor problem, tone, posture, and motor problem, they may have other associated problems, musculoskeletal, intellectual, speech, visual, hearing impairments, etc. Epilepsy, that's why we may send those children for EEG and prescribes anti-seizure medications. They may need aids like glasses for their refractive errors, hearing aids for hearing impairment. They may need splints, special shoes, wheelchairs, and communication skills. There are many causes and risk factors, but we have to remember that the maternal and prenatal causes account for 70 to 80% of the cases of the causes of cerebral palsy. Perinatal accounts for about 10%, and the postnatal factors. Can we prevent cerebral palsy? Well, there are many suggestions and many studies. The proven one, the proven preventive measurements are the vaccination against infectious illnesses with MMR, for example, iodine supplements, prevent Kernicterus hyperbilirubinemia encephalopathy by giving anti-D for Rh negative mother. Take care of a preterm children, transfer the very preterm infant in utero to tertiary center. And there are other probable, possible, and doubtful preventive measurements. What is the prognostic features of those children? It depends. The prognosis depends primarily on the severity of the physical and mental handicap and the presence or the absence of associated disabilities. Well, all children with spastic hemiparetic changes or spastic hemiparesis became ambulatory. يعني كلهم بالنهاية راح يبدون يمشون. هذا شيء مهم نخبره للأهل. But those with spastic diplegia will be ambulant in 86 to 91%. About 25% of those with extrapyramidal cerebral palsy are being able or ultimately being able to work competitively. But the most severe type is the spastic quadriplegic type, which has usually poor prognosis. Those with mild to moderate disability live up to 35 years, and those who have profound handicapped, who are profound handicapped and immobile, more than 30% of them die before age of 3 years. Thank you.